And the great Stevie Ray Vaughan brings us home again, and welcome to another edition of In the Dugout. I am your host, Mike Stenhouse, and I'm wearing, for my dugout hat today, I'm wearing my blank hat. This is a hat I'm going to wear a lot. Because, when you just have a blank stare in your face, you just can't believe the things you're seeing, the things you're hearing, the things that are being done to the people in this state, the people in this country. And then there's nobody else talking about it. Nobody else pointing it out. Almost you got a blank stare, so I got to overcome that and talk to you. So again, this is In the Dugout. We are the ones who aren't afraid to talk about issues and angles on issues that you just don't hear about anywhere else. This is what this show is all about, and this is what why you should tune in. We're gonna start trying to do our shows a little more regularly, so you can we can get more perspective, especially next season baseball next year when the new session starts, and they try to pass more bills on us. Just wait till you see what they're going to try to do with us next year. In fact, they're trying to do it right now. Right now, we're seeing the General Assembly is meeting as we speak, and they are about to pass. They're debating this horrid budget that's going on right now. Some of the Republicans are putting up a good fight, but when you're outnumbered, 65-10, there's not much you can do when the Democrats are all going to vote lockstep. So here's what our show is going to be today. We got a very good show today. We got a new guest coming on in a little while. We're going to talk COVID and our center's new CT data in about 15 minutes with Dr. Andrew Boston, one of our favorites. He's a big favorite with you. And we're going to have a new guest on who's done some work. I don't know if he's a colleague, but a friend of Dr. Boston who's done some great statistical analysis on COVID-19. And we're going to take a look at that. But first, I wanted to just, then we're going to talk a little bit about some news from the General Assembly floor, following some tweets from Kathy Gregg at the Providence Journal. So the budget, I'm sure is on track, this transitional budget. And then we'll get, and then I'm going to give you a commentary in just a minute about the state budget and the economy, a little more that I didn't get to yesterday. But I wanted to also first review what I thought was a really good discussion we had yesterday with Judge Robert Flanders. And this is the picture I want you to look at. So this is a picture of a cartoon of the United States Supreme Court. And following their decision not to hear the Texas case that many thought was a legitimate and strong case. So what you have here is you got 3 Democrat appointed judges. You got 4 judges who were Republican appointed but refused to engage. And then you had 2 brave souls, Alito and Thomas, who were willing to engage in these very, very difficult issues. Now, let me just say, this could be total reverse. This could be 3 elephants over here and 4 chickens and whatnot. But if you saw our interview yesterday with Judge Flanders, he was dismayed about the fact that many, while the court system is there to adjudicate issues, many times judges are simply themselves not willing to engage. They're human beings, as he said. They often don't want to, they succumb to public pressure, or they're, he didn't quite agree with the notion that they were afraid, they want to lose their invitation to birthday parties, or to cocktail hours or things like that. But anyway, unless the judiciary, which is human, is willing to engage, while the structure in theory may be there for recourse, if judges are chicken, in that picture, if judges are chicken, then the court system doesn't work. And this is what we have right now. We either have Going back to this picture, highly partisan judges will always vote according to their party, Democrat or Republican. You have maybe you'll have a couple of brave souls who will want to engage, but a lot of times you're just finding chickens who don't want to engage. We saw it today. I mean, I'm not going to get into it other than just mention it as a newsflash, but the big trial with Jeff Britt, who obviously, along with Nick Mattiello, who did what, I don't know, but obviously there was election fraud, the laws were broken, but yet Jeff Britt was acquitted today. Again, the court system, they did engage, at least had a trial. This was a criminal trial, so they had no choice because the Attorney General brought the case. But the judges, just continue to back the status quo, continue to let people off the hook. I don't know, we are not getting justice anymore in our state and our country. And as we talked about yesterday with Judge Flanders, especially in Rhode Island, there are very few avenues for recourse. If there was, again, let's just assume, again, let me repeat what we said yesterday. If there was election fraud at the national level in any of the ways that are being alleged, again, for the sake of argument, let's say there was, there appears to be no avenue to adjudicate that. There appears to be no recourse. Every case is getting shot down before the evidentiary hearings can happen. Either some judge is making some preliminary lack of evidence, lack of bad timing, lack of standing, lack of magnitude. There's not enough votes involved, so we'll let that fraud go because it didn't rise to 30,000 votes or 50,000 votes. I mean, why do we let unconstitutional, fraudulent things, if they happen, why are the courts letting them happen? That's not justice. Political pressure, the timing of the day, the moment. You're not undoing an election if the election was fraudulently done, but yet we're finding that we just don't have a judiciary that's willing to engage. All right, I want to talk a little bit about the economy, and here's another picture I'd like to share with you. And this is really what's going on with our media and with our politicians. Everybody's talking about COVID. Everybody's making contingencies, whether it's weakening our election laws, whether it's shutting down businesses, whether it's quarantining people, whatever it is. Everybody's looking at COVID, but they just don't see this big tidal wave of poverty that's coming, according to this cartoon. Loss of jobs, businesses shutting down, loss of investment dollars. In our case, people moving out of state. Clearly, in this state, the cure is worse than the condition. We're going to have something like 50,000 people fewer working, and the budget they are looking to pass right now is going up. So you have fewer people earning lower incomes are going to be asked to support a much higher state budget. Now, some of that higher state budget is federal money, but still there's increases in state money too. And we call that a death spiral. When fewer and fewer people earning fewer and fewer dollars are asked to support bigger and bigger budgets, guess what happens? Anyone want to guess? When we tax or burden the productive people, the working people, this is what happens. That's a condition we tend to joke about in Rhode Island, but we are losing people. We are, I don't know, very likely, but we are likely, I think, to lose one of our prized, of our 4 congressional seats, 2 in the United States Senate, 2 in the United States House. We're probably going to lose one in the House because too many people are either leaving our state or choosing not to live here because of the uncertainty, because of the high taxes, and because we keep burdening more and more, fewer and fewer people with bigger and bigger spending problems. That makes sense? That's what we're doing in this state. And the governor today was just horrible comments in the paper. I mean, if you look inside her comments today, the front page of the Providence Journal, it just spells everything out. The governor said, well, given these big budget deficits, nothing is off the table. I might have to consider fee increases, income tax increases. She says, we understand that'll hurt our competitiveness. Yes, it will. But, we might be forced to do it. Well, she lied. Everything is not on the table with her. Budget cuts, spending cuts are not on the table. There is nothing. They talk about, well, her and the new Speaker of the House, we can't. Shakarti talk about we can't cut any government jobs. That wouldn't be right. Well, why the hell not? Private businesses have had to lay off people or shut down, even worse, or cut their hours or reduce their pay. But that's unthinkable. It's unthinkable when it comes to a government worker. And you know why? Because those government workers are union workers. You see, she talked about this bogus effort to mandate increased staffing at nursing homes. Nursing homes crushed themselves, at least from a manpower point of view. People are out sick. People are afraid to go to work. They operate on slim margins anyway, but SEIU wants more union members. So therefore, they want the state to demand that nursing homes hire more people. And the governor is willing to go right along with it. Yesterday, we talked about how in the Providence Journal, there was an op-ed from a greedy people who want us to pass in this time of deficit, in this time of economic downturn, in this time when Len Ladaro said, yes, it could be 3 to 5 years before we reach full recovery. They want to increase debt on our state, increase tax burdens on you by putting out $400 or $500 million in new bonds so that private sector unions can get their construction jobs. Buildings we don't need, green infrastructure we don't need, just to satisfy the left agenda. I mean, do you get the picture? We have children not in school because teachers' unions don't want to go to school, don't want their teachers to go to school. Special interests rule this state. Everything, once you get that picture in your head, pretty much every major initiative you see happening in the state is driven by special interest unions. Most of them on the government union side, public worker side, some of them on the private side. The public sector unions are joining with far left groups to push an income tax raise. Well, what would their interest be in that? Well, when there's an income tax raise and there's theoretically more money to spend from that tax, that means you need more union workers to administer those increased programs, whether it's affordable housing, whether it's social welfare, real welfare, SNAP cards, whatever it is. It takes more union workers. Increasing union numbers and maintaining their jobs at the expense of our jobs is what drives this statement. It's sickening. It's absolutely sickening. And you just read, if you just put on that lens, when you read every article, or you listen to every radio show, please put on that lens, and you will see that behind virtually every major policy initiative, it would benefit some union somehow. Minimum wage. Why would unions who pay much higher than minimum wage, why would they be interested in minimum wage hike? We've pointed this out. Many union workers, their wages, while it may be above minimum wage, right now we have $11.50 minimum wage. Maybe those union workers are getting paid $18.50. But you know what their contract says? Their contract doesn't say they get paid $18.50. Many of the contracts say you get paid $7 above the minimum wage. So if the minimum wage goes up, guess what? Union workers go up. And guess what? Dues go up. It's sickening. The governor did not rule out a regional fuel tax. So again, we're all down and out. Family budgets are down and out, but they don't care. They don't care. Small business budgets are getting crushed, but they don't care. We want to add more pain. We're going to increase the price of gas or increase the price of energy throughout the state to satisfy our far left interest group and to maybe generate more money for the state. They care. Again, I've said it many times, and I'm going to say it every single show. This political class cares more about their state budget, their state union worker jobs and local union worker jobs than they do about your budget, small business budget, your job, small business job. It's clear. How can we increase our budget during this time of economic downturn? And then finally today, before we switch over and bring on our guests, the other thing that was being discussed as part of the budget today. So again, remember, this is a temporary budget they're looking to pass. They shirked their duty last June. They did not pass a state budget for 2021, which starts on July 1st of this year and goes through the end of June of next year. Imagine that. We're one of only 2 states, at least we were a few weeks ago, that hadn't passed the budget yet for the next fiscal year. Why? Because they were waiting for every opportunity. They're waiting for a potential Biden victory, which it looks like they get, so they could take that federal money, the big pot of it they refuse to spend. They refuse to give it to the small businesses and to the people who lost their jobs, who needed it most. And they said, we're going to save that money and look for a way to legally apply it to our own budget. Screw your budget. Screw the small business budget. We want to apply it to our budget. I know that we know that money was supposed to go to the people and the businesses of the state, but we want it for ourselves. We want it so we can keep our government union jobs, our special interest friends' jobs. It's disgusting. But as part of this temporary budget, now you're going to be asked to vote. I think it's March 1st or early March on, $400 or $500 million of new spending bonds, new debt on this state. We're already among the highest in the country when it comes to debt per capita, debt per GDP, and all that. And in that budget was the same weakened voting rules. We're going to allow mass mail balloting, and we're not going to check. We're not going to have any real third-party validation of who sent in those ballots. No notary public, no witness signatures. So, the Republicans put up their argument on the floor, but their amendments to demand such were beaten, on the order of 50 to 10 or something like that. One good comment I think I saw from Representative David Place, if I can find it, which I'm not, but he said something like, it's amazing, for 9 months, well, here it is, for 9 months we sat on our hands, we the General Assembly, and we've done nothing for small businesses, says Republican David Place. This is from a tweet from Kathy Gregg of the Projo, who urged passage of the Filippi Amendment. In fact, that was an interesting amendment. This will be the last point I make before we go over to COVID. The governor, as we mentioned, didn't spend the federal dollars on the small businesses, the hurting small businesses in our state, the way she was supposed to. Blake Filippi, the minority leader, apparently put forth an amendment, said, from this point forward in this budget, all that federal money is no longer under the purview of the governor. We want to move it over to the lieutenant governor, who at least says he cares about small businesses. Of course, that would make sense, because this governor refuses to spend that federal money where it was intended to go, instead keeping it for their own state budget. This is a betrayal of you, the people. This is the betrayal of the small business. And Representative Place and Representative Filippi tried to amend that, but that got soundly defeated, again on the order of 57 to 10. So a good common sense amendment to a budget gets crushed 57. All right, the question is, so have they been betraying us when it comes to COVID as well? Are we getting the truth out of our elected officials? So let's bring on our guest today. And if we can bring them onto the show. He's a regular on our show, Dr. Andrew Boston. Andy, welcome back to the show.
Hi, Mike.
And we have a new guest, Todd Kenyon. Todd, welcome.
Thanks, Mike.
So, Todd, you're an engineer. Everybody knows Dr. Boston's credentials, Brown University trained epidemiologist, clinical and trialist, clinicalist, and all that, all those good doctor terms. You are an engineer and data guy, Todd.
Yeah, I'm just a guy who likes to look at numbers. I've been an engineer. I'm a financial manager, a chartered financial analyst. I've also got a PhD in biology. So I've done a few things that involve looking at numbers and analyzing things, let's say.
Well, I love your mad scientist hairdo. And Dr. and Andy, yeah, we got to cover that. We got to cover that.
We got to put a cap on, huh?
Got to put it now. Now, Todd, I'll have to teach you this. We're in the dugout. I don't know if you know, but I used to play big league ball, and so this simulates. Okay. So we're in the dugout, which means you got it. Next time you come on, you got to have a baseball cap on.
Okay, we'll do.
Because we're in the dugout. So all right, so. I don't know where to start. Andy, let's start with you. You know, I know you've produced a lot of charts. So here's what we want to cover today. We want to cover just a little update on the COVID situation. We want to take a little deep dive into the cycle threshold data that our center obtained and reported on last week. And then we just want to have a talk about vaccines as well, since those are beginning to be rolled out. So, Andy, I'll throw it to you and tell me what to bring up and what you want to talk about.
I did want to just raise one issue that's, again, I like to try and bring up some reassuring things. So Todd's familiar with this database, but the Health and Human Services has hospital utilization data nationally and then state by state. You know, they do the best they can with direct feedback and some projections, but as of yesterday, in terms of total hospital bed occupancy, they said nationally it was running at 74.2%. 15.9% of those total beds were COVID, and then ICU.
Is this ICU or regular hospital capacity?
This is percent of the total of the inpatient census. 15.9%. And then ICU was running at 63.9% capacity. They don't get any more granular than that in terms of like what percentage across the country is ICU COVID. But so Rhode Island has higher numbers than that. And some of it I think has to do with capacity. I mean, we have a small hospital system basically in this state, even compared to states that have comparable or smaller populations, like some of the states out west. But at any rate, total of 86.7% hospital beds, and I understand from people that have a lot more financial.
Oh, is that high? Is that near crisis level, or is that
no? As a matter of fact, and maybe Todd wants to weigh in on this. My understanding is from some economic analysts is that hospital execs like their hospitals to run at about 85% capacity.
Yeah, correct.
And then,
let me just jump in there. One of my roommates from college is a high-level doctor at Emory University, Atlanta, and he said, "Yeah, everybody's talking about this 90%." He said, "We always run at 85% capacity. That's nothing new."
Yeah,
said,
apparently that's a sweet spot economically.
So again, they're trying to scare us, but you're trying to say, don't be scared by those hospital utilization numbers, right?
Right, and then for COVID, of the total of hospital beds, it's estimated that it was 25.4% were COVID beds, and then we have a higher ICU capacity, but I think it's really limited. We only have about 260 ICU beds in the whole state.
Okay,
and it was 91.3% ICU beds. So there's a little bit of, potentially a little bit of
wiggle room there, but we're getting close. Okay.
Yeah.
And then in terms of the charts that I sent you, I think the big one, first we can start off. Well, this looks, Mike, I don't know if this trend, maybe we reached the peak. I mean, let's hope so.
So explain what we're seeing here. This is the weekly average positivity rate, right?
Yes. So we went up to a max, and they're always behind. So this is only through the 12th, and here we are already at the 16th. So we were up to 9% last week, and this is
2 weeks ago. Yeah.
Yeah, these are the COVID-19 tests, positive tests, and we're going to get into some of what this really means. But at any rate, these are all comers, positives. And then, we came down a bit. So that's something that's, hopefully a positive trend. The most important though is this big chart that we go over every week. And, there's still this steady rise in hospitalizations. And
which is what line?
Which is the green line.
Okay, yeah.
And there's a slow uptick in ICU, ventilators a little bit. Deaths are basically flat, but maybe up a little bit since this really low period at the end of the summer into the fall. But again, there's a disproportionate increase in the hospitalizations, and that's in the next little graphic that I made for you, Mike. If you want to take a look at that, I compared a couple of dates, months apart.
I think I misplaced that one. So go ahead and just say it verbally.
Yeah. Basically, let me grab my own copy. It was pretty striking that you can look at the percentages. Excuse me, the percentages of
so it's basically this. It's a numerical.
So if you look at 2 days,
right?
that are 7 months apart, the 12th of May versus the 12th of December. On the 12th of May, there were 293 total hospitalizations, but 23.8% of the patients were in the ICU, 70 patients. 49 patients, or 16.7%, were ventilated, and there were 22 deaths in that period. So 7.5% of that total expired. Fast forward to the 12th of December, and there's 433 total hospitalizations. Only 10.9% are in the ICU. So that's compared to 23.8%. There's only 31 patients, or 7.2%, that are ventilated compared to 16.7%. And there were 12 deaths in that 24-hour period.
So what you're saying is, while hospitalizations and tests are going up relative, as a percentage of that, the number of critical cases is going down.
Right, and to me, as putting back on my clinical hat, that tells me that there's something better in terms of reduced virulence, better management, more inclusive hospitalizations, to use a generous word,
right,
in terms of people coming in for early treatment, right, and people having what used to be called short stays, observational, right, admissions, now counting as full admissions.
All right, let's go to Todd. Todd, we're not going to look at your chart yet. We're going to do that when we get to the CT data. But here's your comment. You've done a lot of independent. You're with a group that's, what's the name of your group again? It's called rationalground.com. I encourage anyone to go there. You and your team there have done some amazing analysis, and you've got some really good, funny infographics too, or I don't know if they're funny, but they're telling. But right, what does your data analysis show? Andy talked about this in Rhode Island. Are you looking at things more from a national level?
Well, the group certainly does. And we have, in Rational Ground, we have folks that represent many different parts, many different states of the country, and even folks who live in one state and may focus on another state for whatever reason. And even worldwide, we're looking at the data. But, so I keep abreast of that, and I'm always looking at that. But certainly the majority of the stuff I've been doing is focusing on Rhode Island, and my own analysis mirrors Andy's very much of what I'm seeing in the hospitalization data versus ICU versus fatalities. The ratio of those things is much larger now than it was in the spring. So that the hospitalizations are decoupling effectively from the fatalities. There's way more hospitalizations relative to the fatalities than we saw in the spring, and also relative to ICU.
What is the case fatality rate across the nation right now?
That's a hot question.
It depends. It depends if you look at what we have to project in terms of the total pool of people who have actually been infected, which is massive at this point. I mean, CDC has made various estimates. Independent epidemiologists have made various estimates. But it seems to be overall comparable to some of the pandemic flus we've had historically. So somewhere about 0.25%, perhaps overall. There are even some lower estimates, and there are certainly other parts of the world. The other thing is, Mike, is that we really have to be specific about age strata, about age groupings. If you look at the population less than 70, and I even sent you a graphic about that. You can see, I mean, this is just for Rhode Island, and this is completely crude. This is just looking at the total, literally looking at the total population, without even considering who might or might not be infected. And you see this dramatic shift comparing those less than 70, and that's basically the entire workforce, versus those greater than or equal to 80. And it goes from a death rate, a crude death rate of about 34 in 100,000 for those all comers, less than 70 years old. So all the people that have terrible comorbidities, they're not excluded, versus those greater than or equal to 80 years old. It's 56 times that rate. It's 1,891 per 100,000. And so, the age is a major consideration in gauging risk for coronavirus.
If we were to sum all of this up, we're seeing big increases in cases. We're seeing, but we could say that's because we're testing more. We're seeing increases in hospitalizations. We're not exactly sure, as we've discussed, why, but so while those are going up fairly rapidly and causing alarm to a lot of people, when you look at the critical cases and you look at the age groups of those, like Todd said, they're decoupling. They're not on that same alarmingly increased path, and it is only occurring within certain segments of the age population, right? So, all right. Let's go to the CT data. So this is a long story. So we've been talking about how important the cycle threshold data is, because not all positive tests are the same. You could have a low viral load. You could have a high viral load. You could be contagious. You could be non-contagious. You could be infectious where you'll get symptoms, or you could be non-infectious so you don't get symptoms. And apparently, and while your cycle threshold data could change over time, it could increase or decrease, but still it is an indicator of how much virus you have. When you match that with the fact of whether you have symptoms or not, right? Now you can begin to put a more accurate prognosis together. Is that correct? But yet this data is being withheld from the public.
Yeah, and Todd did something really beautiful with that. Do you have his graphic? And he actually related it to what we really want to know. It's inferential because he's got the Rhode Island Department of Health database for the entire population, and then he's got this select sample that we all worked for to finally get them to release in terms of the cycle thresholds, at least from February through the end of June. But Todd did something really elegant here. It's
what I want to do first,
but it gives us a snapshot.
Before we turn this over, I just want to quickly go through our center's website, what we reported last Friday, and then we'll show how Todd really took it to another level. So we got a hold of about 10,000 tests, an enterprising citizen, and I'll mention his name, Roland LaValle. In fact, I forgot to invite him on the show.
Well, Mike, it's really what it is. It's the way they run the test. It's 5,000 tests, but they look at two genetic markers.
Right.
But you could say it's really still 5,000 tests. And it's actually done very nicely by the state's lab.
So as you can see on this chart here, any test under under 40, again, the higher the test number, the CT value, the lower your viral loads. But anything under 40 triggers a positive. Anything over 30 or 33, different people, is pretty much considered to be not infectious, not contagious. And you can see, look at the high numbers of tests in that sample that are above 30 right here. So in fact, over half of them are above 30. And then here's a plot of that by month. And you can see that the cycle threshold is going up from March till June, which means the level of viral load is going down in those positive tests from March to June. First of all, why would that be? Why would viral loads change over time?
Well, this is where I think Todd's analysis is really helpful. Just one little caveat is that the cut points that we use that have had at least some sort of clinical or biological validation have to do with your ability to culture live virus. So it's increasingly unlikely that you'll be able to culture live virus the higher the cycle threshold. When you pool the data together, it seems to go down considerably above 30, and certainly by the time you're above 33, or if we have to be as grouchy as Anthony Fauci, above 35, you're not culturing virus.
All right, Todd, why don't you explain what you did with this very cool chart? Take your time and really explain it to everybody.
Sure. So let's take a look at the blue dots on there represent, they're similar to the image you showed from your graphs. The blue dots are the daily average CT values. So you can maybe see the date scale on there. It's from March through April. The date scale is at the top of the image there. And so that shows the average CT value. I flipped it. So the average CT value is actually, it's going up, but the curve looks like it's going down. So that's the dotted blue line. Right. And if you look at the CT value on the left-hand axis there, because a higher CT value means a lower viral load, I basically flipped it to make this blue line effectively represent viral load. Yeah. So and
there's that average line right there, right?
Right. So that's just a linear regression of those dots, and that just shows that the CT value as we move through March, April, and into May. I stopped this at the beginning of June because into June the tests got very sparse and the data kind of jumped all over the place.
Very limited data, right?
Right. So I stopped it at the end of June, but we can see that early on the CT values were firmly in this red area. So you can argue about exactly where to put these three zones. I have the red zone being likely infectious. I have the yellow zone being tests that represent people who are maybe infectious, and then the green zone representing people who are probably not infectious. And certainly as you get further down into that green zone, they're certainly not going to be infectious. So if we look at, again, just focusing on that dotted line and those blue dots, we can see that as April progressed into May, that average value dropped into the maybe infectious zone and all the way into the not infectious zone. So I found that very, very interesting. And so I said, well, how does that relate to what we were seeing with fatalities through that time period? And the thing about any of this data, which I'm sure you're all familiar with, is that a case happens on a given day, and it's going to be a certain amount of days until, sadly, a fatality may happen relative to that case. It takes 2 or 3 weeks, let's say, from the time someone's diagnosed till unfortunately the time when they might pass away. So this red curve I have on here is Rhode Island's fatalities per day, which there's an axis on the right. The vertical axis on the right shows those number of fatalities. It's just a 7-day moving average, so it's just a smooth curve. And I shifted those.
You offset it by the 2 weeks?
I did 3 weeks in this case, but it's the same. It's the same conclusion where they use 2 or 3 weeks. That the exact offset doesn't matter, but the point is it needs to be offset some. So what we're seeing is that again, as those CT values of the tests drop out of the red zone, the fatalities are also dropping. And as they drop through the yellow zone and into the green zone, the fatalities are basically dropping away to nothing. or relatively few.
So the significance here is, so here we see the data matching the theory, right? Because in theory, if people are less infectious, if they have lower viral loads, then they won't get as sick and they won't die as often, right? I mean, that's the theory, right?
Yeah.
Correct.
And here we see the data almost perfectly lining up with that theory, right?
It's really elegant. I mean, you know, it would, if we could get cooperation, this would be a beautiful research project to be able to get
fantastic
the de-identified more clinical information on just on those 5,000 people who were tested, and then be able to look at hospitalizations and potentially mortality, because it is a fairly large sample, 5,000. It's not a small sample, you know. But Mike, what Todd did is a beautiful graphic. But the tragedy of it is that where are the public health people doing this? You know, why does Todd have to do this? Why do I have to do this? You know, and I will say that in terms of the only real clinical correlation I could find, there was a very nice study done at Montefiore Medical Center in the Bronx, in the teeth of the big hit that they took in the Bronx. And the Bronx was one of the hardest hit places in the entire country, in the world. And what they found is that even in a clinical population, you know, hospital admissions, the baseline cycle threshold, you know, moving this away from a general population, the baseline cycle threshold at hospital admission was predicting mortality, and they had about 270 deaths. And they broke the distribution up into quartiles. And if I remember this right, the lowest quartile of cycle thresholds, which was down in the low 20s, was predicting 3 to 4-fold the amount of death, adjusted for all these variables, all the information that they had at admission, relative to the higher quartiles of cycle.
So what's the bottom line conclusion to that? Because I'm going to get to our next up. What's the bottom line conclusion of that?
That whether you're looking at it the way Todd did in this elegant analysis of the data that we got, or you're looking at it very clinically, where you're able to adjust for risk factors for COVID in an inpatient hospital setting, it's predicting mortality. I mean, right. You know, in these two quite different populations.
But more than so. Go ahead, Todd.
Yeah, Mike, that's what I just wanted to say. That what struck me when I did that graph was like, whoa, this is huge predictive value. I mean, we've wanted to get our hands on this data just to get an idea of what kind of distribution is there with these cycle thresholds, because of course, as you said, we know somewhere over 30, they aren't really that meaningful. But when I looked at that analysis you showed, it was clear to me that, well, if you were tracking the CT values, you could say, well, this thing is getting worse, and we could potentially predict more mortality 3 weeks from now, 2 weeks from now, what have you. Or we could say that, well, the pandemic is upswinging again because we're seeing the CT values go down, which means the viral loads go up. And this appears to be what the data shows, yet nobody is looking at this data. Nobody can even get the data is the problem. I mean, I think more people would certainly be looking at it if anybody could get it. I mean, you guys, when I posted this on Twitter, people all over the world went crazy about this data because it has effectively been released nowhere in the world. And you guys were basically the first ones to get it. And it's ridiculous. It's negligent, basically, that this data is not being released and isn't being analyzed.
It adds insult to injury is that the public is paying for these data, basically, out of tax dollars overall.
And as we talked last week, you know, so we're talking at a mass public reporting level. But at the individual level, it's even more important. I mean, if you've got symptoms or you're going to see your doctor, I mean, just think how critical it would be for that doctor to know at that point in time whether you have a high viral load or a low viral load. I mean, that could make all the difference in the world.
Well, Mike, we talked about this before, Mike.
Right? I mean, it's your personal data, and they're keeping it from you.
Right. Well, India is at least parts of India are attempting to use these data clinically in a very, you know, they have very, very simple, we could call them crude cut points. I don't think they're so crude, but, you know, less than 20 to 25, above 25, they really don't look at. and they're using them to triage patients for potentially, particularly if they have any risk factors for hospital admission, or to be outpatients who are being watched by a nurse practitioner.
All right, let me again give a plug to Roland Lavalley, because I want you to think about this. Judicial Watch. You've worked with this is one of the most prestigious, powerful legal entities in the world. They put forth a records request for this information, and sort of got denied and slapped with a high fee. Patricia Morgan, a former state rep, now elected, state rep again, elected, former governor, asked for it, and she was denied. But yet Roland Lavalley asked first. They said, no, we don't. Asked, no, we don't have the data.
Right.
And then he said, all right, let me ask a different way. We don't have the data the way you asked for it. So Roland said, I'm not going to give up. Let me ask for it a different way. And he asked for it a different way, and he got it. Now,
but in between, Mike, in between was your petition.
Yeah, well, I want to mention that too. While Roland was enterprising, we might have applied a little pressure too, because as of now, thousands of emails have hit inboxes of health officials and Governor Raimondo's staff demanding the release of this. So Roland was able to get, so I think it was a good team effort, but I want to give most of the credit to Roland. And again, want to thank him for that data where others much more powerful and insider people have failed. All right, I want to move to something new. Todd,
yep.
Your group has also looked at, do masks work? What are we looking at here?
Yeah, well, this is for the whole U.S. and this is a daily case graph, and it's just basically showing that the areas that had a mask mandate actually have done worse as measured by cases than the areas that have no mask mandate.
Wait a minute. So let's say that again.
Yeah.
Where masks
it's the opposite of what you would think.
They're getting a higher incident of cases than where there is.
Right. Right. And you could argue
masks worked.
Right. Well, that's right. And you know, a lot of people think they work, and it's obviously a real hot button topic. But we have, if you look on Rational Ground, there are plenty of graphs where there's an individual who focuses on this, and he looks at different regions, and he marks on the graph where they made the mask mandate.
Well, let's look at some of that.
There you have one. There you go.
Yeah.
So
Oregon puts in a mask mandate, skyrockets.
Right.
Kansas, same thing, right? Go ahead, talk, Todd. Go ahead.
So the thing is, if instead of mask mandate, it was something else that people think doesn't work or thinks harms people with COVID, then everybody look at that. That's evidence that whatever that was makes things worse.
Well, the mask is a super spreader event. The mask mandate is a super spreader event. I mean, this is how they but I'm being facetious, obviously, but this is how they use those events.
What would be the medical reason for that? Why would wearing a mask? I mean, is it because of the mask, or is it because people are also self-quarantining in close quarters at home? Or
there's a couple of hypotheses here with why that could make it worse, and you know, Andy, of course, is aware of this too. One is that it provides false protection, so people do things they wouldn't do without the masks on, and the masks aren't really doing anything as far as protective, so it creates riskier behavior, and it doesn't provide any protection. Another interesting one, though, or potentially more interesting, is that the masks themselves actually make the situation worse because they aerosolize the virus. So
what does that mean?
Well, so what that means is, if you're breathing through a mask and you consider it to be a fine mesh, and you know, obviously most of these, the great majority, are not medical masks, they're bandanas and things people make themselves, and you know, who knows what, right? And a virus is very tiny, of course, relative to the holes in the mask. If you blow through it or cough through it or talk through it, you're basically forcing the droplets that contain the virus through the mask and creating an aerosol. So in other words, and I'm not saying that there's proof that this happens yet, but this is, I mean, there's mechanical proof.
An aerosol versus a droplet.
Right. So an aerosol is going to float in the air. And so you may be taking something that otherwise would be contained in a droplet and fall to the ground within 3 feet, and turning it into an aerosol, a very tiny particle now that floats around in the air. So perhaps you're actually making it more contagious. And, just from a strict engineering standpoint, you can look at what happens when you force droplets through a fine mesh with some force. And what happens? They get aerosol.
So a mask can actually change the physical size of the diseased
particles. Right. So it goes from being a droplet to essentially being this aerosol.
Wow,
which
I've
can
never
float
heard that
in the air.
before.
It's,
That's just a theory?
It's a theory, and Andy, you may have some insight on that.
Yeah, I mean, obviously the virus itself is not, it's a minute
Right.
particle, but yeah, how it's being delivered could change from a more globular droplet to a finer, think of it as a finer mist or something like that, encompassed in the term aerosolized. The other thing, the other piece, the other really, I think, important aspect of this whole discussion is that we've had 2 decades of experience, since the alerts first started to come out again about, potential pandemics, particularly the context was influenza. We've had over a dozen trials, only one with COVID, but at least a dozen with influenza, in all kinds of iterations, randomized controlled trials, where masking, unfortunately, was not found to be protective. And these studies really ran the gamut. And they included studies of close contacts who were already infected, where the infected party was masked only, the uninfected party was masked only, both parties were masked only, and randomized on households. There were at least 7 studies like that. None of them were positive. There was a study of Hajj pilgrims where tents were randomly assigned to masks or no masks. They become
a political security blanket. Yeah.
Yeah, and there were studies of students that were negative. And then along comes the Dan mask trial, which was conducted in Denmark. They wound up keeping in the study about close to 5,000 people. And there again, it was at a point where there wasn't a high infection rate in Denmark, but they had enough events, and there was no statistically significant difference between the masked and unmasked groups for COVID.
All right. All right. We got just a few minutes left. We're going to talk about vaccines for a few minutes, but I just want to remind you, if you like the show and you want to get notified when we're coming up and live next, hit the subscribe button here on this YouTube channel, whether you're watching live or whether you're watching after the fact. Let's increase our show us you like our show and appreciate the good information here from Dr. Boston and Todd Kenyon. All right, let's talk vaccines. Todd, you and I talked earlier today, and I'm not a statistician. I don't have the engineering PhD that you have, but it doesn't seem like when they say these vaccines are 95% effective, it seems like they're not talking apples to apples here. Have you put any thought in? The numbers just don't seem like the way the media is feeding it to us. Like that's what the numbers are saying. What's your analysis?
Well, I don't have a great analysis on this, and I was going to look into it further today, and I didn't. But I will tell you that I've had the same feeling that the way it's reported, and Andy might have a better insight. He may have looked at the actual data from the trials themselves, but it's let's just say it's being spun a little bit as far as the effectiveness. And heck, I hope it is 95% effective, right? Sure. I mean, let's hope that it is. But I think it's a little too early to say that. Andy, what would your input be on that?
I was all sold on the numbers as published and as I read them until a colleague of mine pointed out a caveat, which I still haven't had a chance to really think through. In other words, that if you looked at the raw numbers of both the trials, the Moderna and the Pfizer trials defined as outcomes, it really was a 95% reduction. If you look at the total number of infections that they counted, and they did have a clinical definition. You couldn't just test positive. You had to have a real respiratory illness syndrome that anyone would recognize with basic symptoms. So that was
interesting
good.
That they use that. Interesting they use that for the trials, but not for testing people in public.
Exactly.
Right.
Exactly.
Yeah.
But the caveat now is that there's some ambiguity about whether people were allowed to be in who'd had some kind of infection previously. And that became a little confusing to me. I remember going. I remember at one point I had read through the protocols, and it sounded as if that may have been a very soft definition. The previous infection, it could have just been a verbal report, and then you would hope that those people were brought through, tested by throat swab testing, the RT-PCR we're talking about, plus an antibody to rule them out. But according to a colleague of mine who carefully read the New England Journal report that just came out, that was a little ambiguous about how they defined that. And they also looked really at the final people who had the outcome as being defined only after the second dose. So I don't know. So let's say there's some ambiguity. It's down more, to 80%. If that's still highly effective. The question is going to be, after looking at people for 6 months, and applying it, these trials are pretty big, but they're not like the hundreds of millions that they're planning on giving it to. Are there going to be some unusual adverse events that you only see when you expose this to a large population? And that's the concern, because not that they did anything wrong or that they're concealing anything. It's just that it's only been out for 6 months.
What would you consider an adverse event? Near term, like 2 or 3 days of maybe a red and sensitive
no. I'm talking about things that we've seen in the past. Or are you talking about
something more permanent and long term?
I'm talking about things that we've seen in the past. With the swine flu vaccine, where there were a number of cases of Guillain-Barré, this paralysis syndrome, things that could be potentially bad. And eventually, there was an offset, and it was realized that this really wasn't worth pursuing. The 1976 swine flu vaccination program under President Ford. So I guess that's my concern, is the unknown. In terms of the principle, though, it's a very nice, safe principle. Which is why the whole mRNA vaccine was introduced, because they figured, it's a transient.
We're not actually giving you the disease, right?
And it's quickly degraded. Right. It doesn't interact with the genome, which is, people say, you say RNA, that it's going to interact. It doesn't. So it had that safety profile, sort of, at least in theory. But until you apply, to apply it to hundreds of millions of people, and the other issue that's critical is this has to be voluntary. This cannot be mandated. It's one thing for a nursing home to say, look, we've had terrible experiences with COVID-19. If your mom or dad wants to stay in our nursing home, they're going to have to get vaccinated. I think that's acceptable.
I agree. We agree with you there, Todd. What kind of data are you going to be looking at when it comes to vaccinations?
Well, it's going to take some time before I think we get anything meaningful out of the vaccination data. It's going to just, we're going to watch for everything from cases to fatalities. Of course, one of the things that if we're defining cases with PCR tests like we're talking about, you get vaccinated the second time, you could still test positive. Right. Because you could have remnants of RNA in you that the PCR test still picks up. Cases, who the heck knows what's going to happen with that? Depends on basically how they define cases. But hopefully we should see hospitalizations and serious events go down.
Right.
And they believe they're targeting the most vulnerable, although there's some arguments as to who they're vaccinating and who they should be vaccinating first. But I won't get into that. But if we're protecting the most vulnerable and it actually works, then those are the ones who have the adverse outcomes, and that should disappear quickly. So we should see hospitalizations, we should see deaths, ICUs go down relatively quickly if this thing starts kicking in meaningful numbers.
All right, last question for both of you. Andy, you and I have talked a lot about it. I've talked about it quite a bit on my shows, even before we had Andy join us. And Todd, I don't know if there's any statistical or comment you have on it. But what we're talking about here with the vaccines is getting our population to a state of herd immunity, right? Now, herd immunity and chloroquine has become an evil word. A lot of people think herd immunity means let's just let sick people and old people catch it and die, and then the survival of the fittest, and then everybody else will be fine. That's not what it is. But in order for, there are certain people, right, who are naturally resistant to the virus, or other people have antibodies after having some form of the virus. And then there'll be a large population of people who get the vaccine. And those three things combined to reach a certain level of the population, there's no place left for the virus really to spread, and it will start dying out. Have you ever done any kind of, some people think it could be as low as 60% immunity before you get to herd immunity. Some say 85%. Do you have any thoughts, Todd, on what that should be, or looked at that?
It is definitely a hot button topic. It shouldn't be. Herd immunity is just a thing that exists. It shouldn't be. It shouldn't be. Right. It shouldn't be a political thing. It's the end point to any sickness like this. Right. Eventually, some type of herd immunity is going to be reached. We're going to get there one way or another. Right. And like you said, in this case, we probably have a certain amount of people who may have had pre-existing immunities to this through cross reactivity with
T cells and all that, right?
Other viruses, right? Things like that, and then we've got the percentage of people who've had the thing already, right? And we don't, and as we talked about earlier, we know how many cases have been tracked, but the infections are way larger than the cases. We obviously don't catch everybody, and so in the spring we were catching only a tiny fraction, so it's multiples of the cases. So we have it could be 100 million people, it could be 50 million people, whatever, who've been exposed to the virus. And
we have no idea, do we?
We can estimate, right? We can only come up with estimates. And so you have that, and then you have the people who get immunity through vaccination. And of course, there's going to be some overlap here and everything else, but sooner or later, like you said, this combination is going to hit the point that we require for herd immunity. And of course, on the first page of the Epidemiology 101 textbook is this equation that's 1 minus 1 over RO equation that I keep seeing trotted out by these supposedly learned epidemiologists. It's the most, that gives you a 70% or plus or minus level of immunity to get herd immunity. But there are so many variables that can feed into that equation, and those variables can be within a small region. It depends on the mobility. It depends on, there's a whole lot of things, but it's probably not 70%. It's probably notably less. And Andy, I think you could chime in on that.
All right, Andy, why don't you wrap up our discussion with any final thoughts?
The classical, the classical herd immunity was actually from the pre-vaccination era. And it had much less dramatic goals. It was simply to stop the spread of epidemic death and severe disease, as opposed to the kind of model that emerged with vaccination for diseases, frankly, much worse than coronavirus, like smallpox, where you were looking for a disease eradication model,
right?
And that can go up to 85-90% that had to be vaccinated to reach that kind of herd immunity. So it really depends what the goal is. As Todd indicated, there's a lot of natural herd immunity already out there. There's no question about that. And if we define it clinically in terms of preventing severe disease requiring hospitalization, God forbid, causing death. So you could argue that if you did a very strict, targeted approach to the institutionalized elderly first and foremost, then to the frailer elderly in the community, and then going down, regardless of age, to the truly frail across, age ranges.
Right.
That would achieve the goal
without
any kind of mass
immunization
of the rest of healthy society.
Yeah, it's just kind of common sense, isn't it? All right, Andy Boston, thank you very much. Todd Kenyon. Hey, we come back on our show sometime?
Sure. Yeah, thanks.
Yeah, when you got some interesting data, send it our way.
Yeah, you too, Andy.
Andy, thank you again. Todd, we'll talk to you soon.
Yeah. Take care,
guys. Take care. Thanks, Mike.
So, let me just remind you that Friday's show is going to be we're going to talk, might be probably the last time, even though it's long shot stuff, it's constitutional real stuff. We're going to talk, you want to call them conspiracy theories, you want to call them Hail Mary passes. I'm just going to call them, these are still constitutional avenues that are available. to the president. As a long shot as they are, these are constitutional avenues that need to be pursued. And we're going to go over some of that. And we're going to feature, as of now, we've been promised to have an interview with Senator Johnson, a state senator from the great state of Michigan, who's been involved in a lot of these hearings and these deliberations over what was the Wayne County vote fraudulent in Michigan, and what again, like we did with our Pennsylvania friend a few weeks ago, what's the real story on the ground in Michigan? What avenues are open? What avenues are closed? What can the legislature do? What can't they do? Certainly doesn't look like the courts are going to decide anything. As we showed you earlier, they've chickened out. They don't want to do their duty. I guess that's their purview, but it's an injustice and it's a betrayal of their oath. So we're going to find out and this Senator Johnson was also former Secretary of State in Michigan. So she's got a really good look at this. So she's going to be our featured guest Friday. For Friday is going to be all things electoral madness, and we will invite conversations from you. Summing up today, again, we've talked really about three massive governmental failures. How the court system, as we just mentioned, are not doing their job, refusing to get involved in thorny cases, even though there are serious constitutional issues here, even though there are issues that extend far beyond, and that's what's of most concern to me, far beyond who's president or not. Are we going to have safe and fair elections in the future in this country and in our state? These issues have to be adjudicated. We have to see the evidence and we have to decide what we're going to do about our elections. I had a proposal today from, I think, Republicans said, we should fund every state should have the same process and machines to count federal elections. We can't tell you how to do your own elections, but we'll pay for the machines. And if you want to use those same machines for your local elections, great. You'll spend the extra money, but if you want to piggyback on it, we need some standardization. We need some rules around our elections. We have seen that state legislatures, state courts are just all over the map, way too political. We need to have elections everybody can trust in. So our government is failing us when it comes to the budget. They're putting the special interests, making sure they get their money, making sure they get their jobs, making sure they get their contracts, making sure the state budget is preserved, making sure those government jobs are kept. But at the same time, they don't give a damn about your budget, your jobs, your well-being. Another betrayal by the General Assembly, by the governor. And then finally, we see how the state is not releasing this critically important cycle threshold data. It could be so helpful in so many ways with public policy for individuals who may test positive to know whether their cases are severe. I mean, this is government failure all around. And all we can do is raise heck about it on this show. And the one thing you can do right now, go to rifreedom.org, and right at the top, you'll see the petition. We'll send emails to multiple state officials, the petition to release the cycle threshold data. All right, no show tomorrow on Thursday, but we will see you Friday.